Good afternoon and welcome to today's webinar focusing on colorectal cancer screening in adults experiencing homelessness. I'm Darlene Jenkins, your moderator for this webinar, presented to you by the National Healthcare for the Homeless Council as part of our spring virtual training webinar series. This webinar is a 60-minute presentation that has been pre-recorded. If you have questions, please enter them in the chat box below the presentation slides. All questions will be answered and posted with the archived webinar on the Council's website at the end of the entire virtual training series. Although the webinar is pre-recorded, if you are having technical issues, you may call the Council's office at 615-226-2292 for assistance. This session is accredited for a 1-hour continuing medical education credit through Vanderbilt University Medical Center. And to claim your credit, please copy the information located in the CME information and follow those instructions. The credit code for today's session is 521408. Again, the credit code number is 521408. And please note that this code is only available during this session. Okay, I think that's all for the logistics. And so now let's get started with our presentation. This webinar has been made possible with support from the Health Resources and Services Administration, the Bureau of Primary Health Care. We have included a webinar focusing on colorectal cancer, not only in recognition of March, with it being Colorectal Cancer Awareness Month, but also because as a training and technical assistance organization, we frequently receive inquiries from health centers asking how to increase the number of adults ages 51 to 74 receiving colorectal cancer screenings, and especially how to increase the number of screenings among adults who are stably housed. So we're hoping after you view this webinar that you will be able to describe at least one type of colorectal cancer screening test. You'll be able to identify at least one challenge that health centers or your health center is facing, and then also identify at least or name one method that can be used to help increase colorectal cancer screenings among adults who are experiencing homelessness. Our first speaker is Dr. Durado Brooks from the American Cancer Society. Dr. Brooks has worked for the American Cancer Society Global Headquarters since 2000. He is involved in the creation and implementation of strategies to improve the prevention and early detection of cancer and to reduce cancer disparities. Dr. Brooks is a graduate of the Ohio State University and the Wright State University School of Medicine. He also holds a master's degree from the Harvard School of Public Health. Before joining the American Cancer Society, Dr. Brooks practiced primary care medicine and served as medical director in community health centers in Ohio. Dr. Brooks' current hometown is Dallas, Texas. I will now turn the presentation over to Dr. Brooks.
Thank you very much, Darlene, and thanks to all of you for joining on the line. I'm going to be talking about colorectal cancer, why it's important to screen everyone, including patients in the environments where you all are practicing, and then talk a little bit about screening options and the importance of discussing options with your patients. So why is screening important? Well, first off, colorectal cancer is the second most common cause of cancer death in the United States, with more than 135,000 new cases expected this year and more than 50,000 deaths. The good news is that About 1.5 million Americans are living either having beaten colorectal cancer or some of these individuals still fighting the disease. But we've made tremendous progress, and as a matter of fact, death rates have fallen steadily over the last 3 decades. As you can see from this slide, going all the way back to 1970, actually, we started seeing a gradual fall. And over the most recent decade, from 2000 to 2011, a 27% drop in colorectal cancer deaths in the U.S. So what's accounting for this? Certainly, we have improved our ability to treat the disease, and we have treatments available today that weren't dreamed of 30 years ago. However, a big part of this drop is because of the impact of screening, because screening allows us to find the disease at earlier stages when our treatments can be more effective. The graph here shows the blue bar are individuals who have been diagnosed with colorectal cancer at the localized stage. That is, it has not penetrated the colon wall. Of those folks, 90% are going to be alive 5 years later. So 90% 5-year survival. Contrast that with the red bar on the far right. Those are folks who have metastatic disease at the time of diagnosis. Only 12.5% of those people are going to live for 5 years. So a huge difference in outcomes associated with finding the disease early. But the other benefit of screening is finding and removing polyps, which makes a huge difference as well. Now, there are 2 major categories of polyps. There are hyperplastic polyps, which have very minimal cancer potential. As a matter of fact, if you have a patient who has a colonoscopy and all that's found are 1 or 2 simple hyperplastic polyps, they do not need any other kind of screening for the next 10 years. They're still considered at average risk. So there's no point in doing colonoscopy more frequently. There's no point even in doing stool tests after a normal colonoscopy. They don't need anything for 10 years. On the other hand, individuals who have adenomatous polyps found are in a very different category, because about 90% of the colorectal cancers we see in the U.S. are thought to arise from adenomatous polyps. Thus, people who have adenomas found during a screening colonoscopy or a diagnostic colonoscopy for that matter, now fall into a surveillance pool, and they need to be evaluated more frequently. The frequency with which they need to be evaluated is going to vary depending on the size of the polyp, the number of polyps found, and other factors. Now, the good news is that the transition from a simple adenoma to full-blown invasive cancer usually takes a long time, somewhere around 8 to 10 years, sometimes as long as 12 or 14 years. Thus, we have a very long period of time during which we can find and remove the polyp and prevent cancer from occurring. So that's the other huge benefit of colorectal cancer screening. We actually can prevent cancer by finding and removing polyps. And indeed, research suggests that we have prevented over 500,000 cases of colorectal cancer in the last 3 decades because of our screening and polyp removal efforts. So clearly, screening makes a big difference. Now, unfortunately, screening, as many other things in our healthcare system, varies depending on a variety of factors, and many of these factors influence the patients that you are serving. Income being one of the big factors, and this graph shows that the likelihood of being up to date with colorectal screening varies directly with one's income. So people who are at greater than 600% of the federal poverty level, that on the bar on the far right, have much, much higher rates of screening than people who live at or below the federal poverty level, as shown by the bars on the left. Screening also varies significantly with insurance status, and these are 3 periods of time, screening rates in 2000, 2005, and 2010. And as you can see, for most of these bars in each 5-year interval, you've seen a significant improvement. However, the orange-red bar at the far right, that represents the uninsured population. And while there has been some increase, the increase among that group has been exceedingly slow. So if you are uninsured, your likelihood of being up to date with colorectal screening remains far below that of others in the population. And then finally, other issues such as education and income play a huge role in the likelihood of being screened. The set of 4 bars on the left represent screening rates based on educational level. As you can see, college grads at about 67% compared to high school grads, about 45% likelihood of being up to date with screening. And again, the income issue is demonstrated on this slide as well. So the factors that influence the likelihood of being screened are unfortunately a lot more prevalent in the populations that you all are serving. That is low educational levels, lack of insurance, and other factors that are associated with low screening rates are much more prevalent in the homeless population. There are also these screening disparities actually are associated very clearly with outcome disparities. And this graph shows the likelihood of dying from colorectal cancer based on one's educational attainment. And as you can see, for individuals who have lower levels of education, the light blue bars, regardless of your race or ethnicity, if you have low educational attainment, you are at higher likelihood of dying from colorectal cancer. But notice in particular that for the black population, they have strikingly higher rates. And as a matter of fact, even college-educated African Americans have a higher likelihood of death from colorectal cancer than, for instance, a Hispanic person who has less than 12 years of education, or even higher rates than white population who don't have a college degree. The reason for some of these racial and ethnic disparities are unclear, but there is still that significant difference among all groups based on educational attainment. And then the likelihood of delayed versus early stage colorectal cancer diagnosis also varies based on a number of different factors, including race and ethnicity, and as I've shown here at the bottom, socioeconomic status. So simply being poor is a risk factor for late-stage diagnosis of colorectal cancer, which, as I showed you earlier, is associated with a much higher likelihood of death and shorter survival periods. So let's talk about who should be screened. This graph shows the incidence of colorectal cancer by age in the U.S. population. As you can see, it actually starts to go up around age 40, and then by age 50, it has a pretty dramatic upward tick and continues to rise throughout the remainder of the lifespan. Because of this demographic trend, and at this point still a little more than 90% of colorectal cancer occurs in the population age 50 and older, all major guidelines recommend screening for colorectal cancer begin at age 50 for average risk individuals. Now, it's also important to recognize who is not at average risk, and that includes people who have a personal history of polyps. As I mentioned, if you've had an adenomatous polyp, you are now in a different pool and you need surveillance follow-up, not screening. If an individual's had colorectal cancer in the past, they're at much higher risk of developing again in the future. Inflammatory bowel disease, once an individual's had active ulcerative colitis or Crohn's for 7 or 8 years, their colorectal cancer risk rises precipitously. And family history is also an important issue. So colorectal cancer in the family or a family history of adenomas in mom, dad, sister, or brother also increases the risk, at least doubles the risk, and possibly raises it even more. And then there are a variety of hereditary syndromes, most commonly Lynch syndrome or familial adenomatous polyposis, that raise risk as well. Individuals who have any of these risk factors are in such a higher risk group that they have a different set of screening recommendations. They may need to start screening at an earlier age. For instance, if a first-degree relative has been diagnosed, mom, dad, sister, brother, with colorectal cancer at age 55, then that the patient needs to start screening 10 years earlier than the age of diagnosis of that index case. So your patient would need to start screening at age 45. In addition, colonoscopy is the only recommended screening test for people who are at high risk. So stool test and other approaches are not recommended for these groups. Now, this only accounts for about 20 to 25% of colorectal cancers we see in the U.S., and the vast majority, as I mentioned, do occur in people over the age of 50 who have no identifiable risk factor other than being over age 50. However, we are also seeing a disturbing trend of colorectal cancer increase in individuals under the age of 50. So we've seen a very steady fall, as I showed you earlier, in colorectal cancer, both incidence and death rates over time. But over the last 2 decades, we've also seen a gradual rise in this disease in younger individuals. Most of this rise is occurring among people who are age 40 to 49, but we also see some increase in people as young as their 20s. Much of this rise is related to rectal cancer, but there is a slower but still important rise in colon cancer as well. And overall, the numbers remain small, relatively small, and too small to justify increasing lowering the screening age for the entire population. It simply is not a large enough disease burden to justify that. But it is important for us to identify whether there may be specific subgroups for whom an earlier age of screening is warranted. And there's a lot of work going underway trying to determine if we can identify who in the younger population is particularly at risk. The reasons for this rise just aren't known, but there are a number of possible contributors, including the fact that we have an epidemic of obesity, and this is occurring in younger people as well. And obesity has been very clearly demonstrated to increase risk of colorectal cancer in people regardless of age. But it may be even more impactful in younger populations. In addition, type 2 diabetes is a standalone risk factor for colorectal cancer, and along with the obesity epidemic, we have seen diabetes rates skyrocket as well. There also are concerns about the possibility of antibiotic use, overuse of antibiotics in people, as well as animals and through animal consumption, being exposed to those antibiotics, and possible changes, for instance, in the gut flora that may contribute to the development of colorectal cancer. And then questions about hormone use, particularly hormone use in livestock, that may be playing a role in this. And then there are other issues, such as the fact that we no longer use aspirin in young adults, in children and young adults, rather, because of the fears and concerns about Reye's syndrome. And aspirin has been very clearly shown to help decrease the risk of developing both colon and rectal polyps and colorectal cancer. So the fact that aspirin has largely disappeared from our therapeutic armamentarium for youngsters may be playing some role in this. And finally, there may be other unidentified risk factors in the environment, such as pesticides or other issues that we simply haven't identified. All this right now is theoretical, and again, there is work going underway trying to figure out which, if any of these, are playing a role in the rise in colorectal cancer among those under age 50. But for now, it is absolutely imperative that clinicians recognize those patients in their practice who need earlier screening. And those are mainly the folks that I talked about earlier who have risk factors. So identifying people who have a family history of colon or rectal cancer or a family history of polyps. That's really important and oftentimes overlooked. Recognizing those patients who may be at risk for genetic syndromes like Lynch syndrome because of a family history of other kinds of cancers, endometrial cancer or other cancers that can be associated with colorectal cancer. And then finally, it is imperative that both clinicians and young adults recognize that if you have symptoms, then screening guidelines are not relevant. So a young adult who presents with rectal bleeding, regardless of age, it should be considered that they have the possibility of having a colorectal cancer. It should not automatically be attributed to hemorrhoids and be prescribed some Anusol and told to move on. I have talked to a large number of individuals who are either have survived early onset colorectal cancer or are fighting the disease, and at least half of them will tell me about a history of a year, sometimes 2 or 3 years of rectal bleeding, abdominal pain, and other very concerning symptoms that were brushed aside by their treating clinicians because they were perceived as being too young to have this disease. So it is absolutely imperative to remember that screening guidelines are related solely to asymptomatic individuals. When patients have symptoms, you need to evaluate them thoroughly. Now, moving back to colorectal cancer screening, there are a large number of screening strategies that have been identified, and this is the list that was published by the U.S. Preventive Services Task Force in June of this past year. And this list is pretty lengthy, as you can see, but all of these different tests have some evidence supporting their ability to decrease the risk of death from colorectal cancer. And thus, they are all now included in USPSTF screening guidelines, and the American Cancer Society guidelines are frankly very similar to these. But the reality is, although we have that very lengthy list, when it comes right down to it, the vast majority of the screening in the U.S. right now is either colonoscopy or high sensitivity stool testing. So I'm going to focus my remarks on these. And in particular, I'm going to talk about stool testing because for many of the patients that you all are seeing in homeless clinics, colonoscopy, particularly as a first-line screening tool, is not very practical. And I believe that one of the later speakers is going to talk about some of the challenges associated with using colonoscopy for first-line screening. Beyond just the simple issue of limited access to the procedure, there are some real challenges for your patients, for instance, just managing to get a prep. Having access to a bathroom facility that they can tie up for potentially hours at a time as they use these heavy purgatives can be a challenge. And there are a number of other challenges associated with getting colonoscopy for individuals who are experiencing homelessness. So I'm going to use the remainder of my time to talk about stool testing, and in particular, fecal immunochemical testing. I will say about guaiac testing that the only guaiac test that is currently recommended by the ACS Preventive Services Task Force, any of the GI guidelines for screening, is Hemoccult Sensa. So if you are doing stool testing and using any guaiac test other than Hemoccult Sensa, quite honestly, you're doing it wrong because the other tests are no longer recommended for screening. But fecal immunochemical test actually has some advantages over guaiac test. They are more specific for human blood, therefore you're less likely to end up with false positive test. And that's important because, again, if you've got challenges getting patients to colonoscopy, you don't want to have to send a lot of patients who have false positive tests just to confirm that that test is false positive. They're also more specific for lower GI bleeding. If it is possible that bleeding from an ulcer or esophagitis can cause a positive FIT, but it's much less common than that sort of positive test associated with guaiac. So again, a lower likelihood of false positive test. In addition, there are no foods or medications that have been demonstrated to this point to cause a false positive or false negative fecal immunochemical test. They have significantly higher sensitivity than guaiac-based tests, at least the handful of tests that have demonstrated their performance in published studies, and I'll talk about them at the very end. And then a number of brands of FIT actually require collecting only 1 or 2 specimens as opposed to Hemoccult Sensa, which requires 3 specimens to be collected. And this is very important, again, because even something as simple as collecting stool specimens can be challenging for someone who's experiencing homelessness. The ability to store stool cards somewhere after they've been collected can be problematic, for instance. But there are a lot of clinicians that frankly question the accuracy and the value of stool testing. So I want to talk a little bit about what we know about modern stool testing, and in particular fecal immunochemical testing. This meta-analysis was published a couple of years ago, and this looked at about 14 or 15 different stool tests that have been used, not all of which were available in the U.S., but all of these used colonoscopy as a way to assess the performance of these tests. And what they found was that in these high-quality studies, the sensitivity for cancer of a range of different fecal immunochemical tests was around 75%. So not perfect, but pretty good. 75% sensitivity for cancer for a stool test is actually pretty good. And the specificity, the bar on the right, over 90% across all of these different brands, again, pointing out the fact that you're much less likely to get false positive tests with these. So usually, if a patient has a positive FIT, you'll find some reason for the bleeding when you send them to the next level of evaluation. Not always cancer, but some pathology. This is modeling data from the U.S. Preventive Services Task Force that they used in developing the guidelines that I pointed out to you earlier. And look at the blue bars at the bottom. They estimated the impact of population-wide screening using different screening methods. COL10Y on the far right here is colonoscopy once every 10 years. And based on their estimates, if you perform colonoscopy once every 10 years on an average risk population, for every 1,000 procedures, every 1,000 individuals screened, you will prevent 24 deaths from colorectal cancer. 24 deaths prevented for every 1,000 individuals screened. That is a really good return on the investment. Now, the two bars on the left, FIT1Y, GFOBT1Y, those are fecal immunochemical testing every year, or high sensitivity guaiac, Hemoccult Sensa, every year. And as you can see, they estimate 22 deaths averted for every 1,000 individuals screened. So 22 versus 24. Is colonoscopy better? Yes. Is colonoscopy strikingly better? Not really. If you look on a population level, that's a pretty marginal difference. So a well-executed stool testing program actually has very good outcomes compared to a colonoscopy-based screening program. And there's some real advantages to stool testing. Number one, it's far less expensive, not only than colonoscopy, but than any of the other recommended screening tests. There's no bowel preparation required. It's done in privacy at home. There's no need to take time off work or no need to have a driver, someone take you to and from the procedure, which again can be a big challenge for your homeless population. It's non-invasive. There's no risk of any injury, unlike colonoscopy, where there are complications at times. And it also limits the need for colonoscopy. Again, for many of you all, you're working in environments where colonoscopy is an extremely limited resource. So limiting colonoscopies only to those individuals who are most likely to gain benefit, it should be an important goal of your screening program. This illustrates the potential of a colonoscopy-based screening program, illustrated on the left. So you refer 1,000 people for colonoscopy. Everyone is going to get a colonoscopy. And of those, a certain number of folks are going to show up. Most actually will show up. But after you do those colonoscopies, you're going to find one cancer in every 400 to 1,000 colonoscopies. So basically, you refer 1,000 people, you find 2 cancers after doing 800 or 900 colonoscopies. 2 cancers. On the other hand, with FIT testing on the right here, more patients referred, 2,000 patients referred. You screen them down, and you then find that a very small number will have a positive FIT. And in most screening programs, less than 10% of patients are going to have a positive FIT. And then you do colonoscopies on that much smaller number of patients. You find one cancer in every 20 or so colonoscopies. So finding a cancer in 1 of every 20 colonoscopies versus 1 of every 400 colonoscopies. Clearly, you're going to find many more cancers doing many fewer colonoscopies. So if colonoscopy is a limited resource, it makes a big difference to use FIT. Now, there are certainly some caveats, and you have to do high-quality stool testing if you're going to have these outcomes, which means, number one, you can only use this for average-risk patients. So high-risk patients need to go directly to colonoscopy. You need to be using either Hemocult Sensa, as I mentioned, if you're using guaiac, or a fecal immunochemical test. Digital rectal exam sampling is not colorectal cancer screening. Keep that in mind. There is no study demonstrating that digital rectal exam sampling is a reasonable approach to do colorectal screening. And the largest study that looked at this, about 2,000 people were scheduled for screening colonoscopy. They all, prior to their screening colonoscopy, had a digital rectal exam sample collected, and then they went for colonoscopy, and the results were compared. There were 21 cancers found among those 2,000 people who were screened. And of those 21 cancers, only 2 had a positive digital rectal exam sample. 19 of 21 cancers that were present at the time that the digital rectal exam was done would have been missed if that was the only test that was done. Any test that only finds 2 of 21 cancers is not a reasonable approach. And then finally, every positive FIT has to be followed with colonoscopy. Now, the last point I want to make is that while FIT is a very good technology, all FIT are not created equal. And in part, this is because the Federal Food and Drug Administration oversees stool testing approval and clearance for marketing in the U.S., and they do not require that these tests show their ability to detect cancer or polyps. A few of the manufacturers have presented that information to FDA, but that's not required. All that's required is they show they can find some blood, and unfortunately, many of the FITs on the market have compared themselves with Hemocult, simple Hemocult or Hemocult 2, older versions of stool tests that are not recommended for screening because of low sensitivity. And that's all that's been needed. So right now, there have been 56 FITs as of about 6 months ago. 56 FITs cleared for use in the U.S. About half of them are being marketed, but of those, only about a quarter, just a handful of tests actually have data demonstrating their ability to find cancer or polyps. And the other thing that some of these FITs do is they claim that you only need to collect 1 sample, but they don't have data supporting that either. So this last slide is a list of the stool tests for which we have been able to find some published data demonstrating their ability to find polyps or cancer. Most of these are single sample tests. They've shown that they have relatively high sensitivity using just a single sample, which again can be a benefit for patients that you all are caring for, although at least one of these is a 3-sample test as well. But if you're using a FIT that is not on this list, you need to ask the manufacturer's representative to show you the data, not that they find blood, but that they can actually detect polyps or cancers. With regard to specimen collection, the one other thing I want to mention is while digital rectal exam sampling is not acceptable, there is a technique referred to as poop on demand, where the specimens are collected in the office in an evidence-based way. And I believe that one of the other speakers is going to address that issue in their presentation as well. So thank you all again very much for tuning in to this webinar and giving me the opportunity to share this information.
Great. Thank you so much, Dr. Brooks. Our next speaker is Dr. Vicki Copeland. Vicki has been the medical director at Healthcare for the Homeless in Maricopa County in Phoenix, Arizona since August of 2014. This is one of the few Healthcare for the Homeless programs operated by a public health department. Dr. Copeland believes strongly in providing high-quality health care for all people in our society. A native of Arizona, Vicki graduated from the University of Arizona with an undergraduate degree in microbiology. She received her medical degree from Penn State College of Medicine and completed her residency in family medicine at Banner University of Medical Center in Phoenix, previously known as Good Samaritan. Vicki is board certified in family medicine and is a clinical assistant professor for the University of Arizona. Now I present to you Dr. Copeland.
Hello, everyone. Thank you very much for joining this webinar. We are excited to be talking about colorectal cancer screening for our adults who are experiencing homelessness. As was stated, I am a family doctor and have previously been in private practice and at a community health center before coming to a exclusively site that serves homeless people. Again, we were one of the original Robert Wood Johnson grantees, and we feel very strongly about the role that we play in serving this population. Last year, we served 6,788 unique individuals, and we provided them with medical care, nutrition, substance abuse, mental health, and dental care. One of the challenges that we know we face is that colorectal cancer is more difficult than some of the other screening tests because people are somewhat uncomfortable talking about poop. They're somewhat uncomfortable about having to provide that as a sample, and they're even more uncomfortable with having somebody look inside their rectum and their intestines. And so we face these challenges whether we're in private practice, but even more so with our patients. On this slide, we're discussing that patients, in order to account for this measure, only need to be seen one time. And so this presents a problem for us because often in a private practice, we've been able to develop a relationship with these patients, and they understand that we are looking out for their health and that we are concerned about their future. In this circumstance, if we've seen the patient one time, they count as a medical visit and they should be screened. Our patients, again, often do not have unrestricted access to a toilet. So in private practice, when you're talking to people about doing a stool sample or a fit test or completing a prep for a colonoscopy, they have their own toilet. They can go to the bathroom anytime they want. They've got as much toilet paper as they want. Where in our site, again, people struggle with that. They have to ask to use the bathroom. They have to ask for toilet paper. They get shooed away from places because people don't want them using their toilets, and it just presents very unique problems. Our patients don't have time often to worry about their own health. They are worried about their survival. They are worried about where they're going to sleep that night. They're worried about what they're going to eat. They don't have time to worry about someday in the future that they could get colorectal cancer. And again, we've already addressed that people living in a shelter or on the street may not even be able to complete a prep for a colonoscopy because they have to carry around often a jug of some liquid. They have to be able to go to the bathroom right away, and that presents complications for them. When people go for a colonoscopy, they need to be sedated. And when they need to be sedated, then they need to have somebody accompany them. Our physicians here in my community will not just release them to themselves. And so even if they're able to get a taxi or a bus to come back to the shelter, they have to have somebody accompany them. I've had many patients tell me I offered to pay them to be my accompaniment. I've said that I would give them my DES or my food stamps or cigarettes, and they try to barter, and they still can't get somebody to accompany them. This is really a very difficult time. Patients also, if they've already had a colonoscopy, we try to obtain that information. We try to get a release of information because we know that counts towards the measure, and of course it counts as their previous screening, so we don't want them to have to go through that again. But often they don't have documents with them. They don't have their address book. They don't have a contact list in their phone because their phone's been stolen multiple times. And so they just don't recall where their previous testing was done or how to contact that provider. When we give people stool cards, again, they don't remember to return them. Their bags get stolen, their bags get lost, their bags get wet. And so even if they've done the stool cards, they don't get credit for it, and neither do we, which, again, isn't the credit we're aiming for. It's the screening. It's the prevention of colorectal cancer. So some of the strategies that we've tried at Healthcare for the Homeless in Maricopa County to increase our colorectal cancer screenings are that we try to ask every patient at every visit. And sometimes this is really difficult because the patients don't understand why we're asking. They don't care if we know. The visits are already full of other things that the patient may view as more pertinent, but we do try to ask them. We have experienced several problems with our electronic medical record about where we're going to document this. And so we've changed our process multiple times, and we've actually started documenting in the medical history whether or not a release of information has been obtained for the colon cancer screening so that we can find it in our next visit. And that's helped some because, again, then we don't have to go searching through documents. We've also changed that we document it as a procedure, and that way we can find it in our procedure list, even if they've had it done at another location. Traditionally, we have offered all of our patients colonoscopy first and emphasized to them that if it was normal, then it would be good for 10 years. We have changed that practice recently, and we are now going more towards FIT testing as a single-step test that can be obtained. We have also involved our case managers trying to help our patients obtain the ROIs, release of information, and working through the barriers that they're going to experience ahead of time so that they know where they're going to prep. They know who's going to accompany them after the procedure, because we don't want these patients either not showing up for the procedure or once they get there being sent home because they don't have a driver. That frustrates our specialists, and it reduces our possibilities of getting our patients in the next time. Our policy has been that if a patient was not insured or otherwise unwilling or unable to do the colonoscopy, that's when we'd go to offering stool cards. Of course, stool cards need to be completed annually, and that presented problems because sometimes we wouldn't get back the full 3 in the set that we need. We'd only get back 1 or 2. Well, then you aren't sure. Does that constitute a screening or not? Do they need to bring you back a 3rd one another time, or do they need to repeat all 3 of them? Sometimes, again, the patients don't return the cards, and then we have to give them cards again and again. And sometimes that can be frustrating for our staff, but I know it's frustrating for our patients because they just don't understand necessarily why we're putting so much emphasis on that. This month, we have implemented our new one-step process, which is a FIT test, and it's called OC Lite S-FIT, and it's from Polymedco. And we're very excited about this because we are going to hopefully increase the screening that goes on in our community and help to prevent colorectal cancer. And the way that we've decided to do it is that we are going to allow patients to use our bathroom the same way we would for any patient who needed to do a urine test. It's no different. It's probably as important or more important. They're just going to enter our bathroom and leave the sample in the specimen window. We are going to make sure that it is tested before the patient leaves so that they do not miss hearing that their screening test is negative, which is wonderful, and that it's good for a year, or if it's positive, what the next steps are. We don't want to have to go track our patients down to tell them that their test was positive, because oftentimes it's difficult to locate them again. We've changed to the FIT test because it is a very good screening test for colorectal cancer. It detects the human blood in stool. It can be done at the time of the office visit. In our case, this is a one-sample test. It's a point-of-service test that's CLIA-waived. We can do it in our office, and the patients can receive the results the same day, and it does not depend on insurance coverage since we are not sending it out. So again, this is our process that we've just implemented. I'm very excited to see how it changes our screening rates and hopefully eventually how it changes the lives of our patients so that it is more convenient for them and a better screening test. Thank you very much for listening, and again, I hope that this has been helpful, and if there's any questions, I would be happy to answer them.
Right. Thank you, Dr. Copeland. I do have one question. As you're talking about the new test, the FIT test that you're starting to initiate, would you consider, is this falling in line with what they're calling poop on demand? I know we've heard that term used. Is that a term that could be used to this type of initiative?
I think it would. I mean, again, the human sphincter and intestine doesn't quite work the same way that the bladder does, and so it's a little bit more complicated for people to produce a poop sample, but I think it definitely would fit into that category because, again, we are giving them the option to do it right then in our office. If they're here and they're able, then go ahead and poop. Yes.
Great. Okay. Thank you so much. We really appreciate that information. Our next presenter is Ms. Angela Sweeney. Angela has been working as a registered nurse for the Harbor Care Health and Wellness Center since December of 2011. She received her degree in nursing from the University of New England in 2005, and she transitioned into the role of clinical coordinator in 2014. Her coordinator responsibilities include writing policies, running reports on quality measures, tracking referrals, maintaining the quality improvement work plan, and supervising clinical staff in the inpatient unit and outpatient clinic at Harbor Homes. Angela was part of the team involved with the Patient-Centered Medical Home Level 3 implementation and recognition. Take it away, Ms. Sweeney. Thank you.
Thank you very much. Hi, my name is Angela Sweeney. I'm the clinical coordinator for the Harbor Care Health and Wellness Center, which is a program of Harbor Homes, which has a lot of different partnership agencies in the greater Nashua area. So I am speaking about colorectal cancer screening. Our screening rates have been fluctuating quite a bit throughout the past couple years. I think a lot of that is related to changing of grants. For instance, we have a grant through the state of New Hampshire for colorectal screening, and in the past it has been to cover free colonoscopies for patients without insurance. So I think that in 2015, our numbers increased quite a bit because of all the screenings that our patients were able to access. This year's numbers, we're still finishing them up in 2016, but as you can see in the slide, in 2015, we were at 52%, and then in 2014, we went down to 31%, and then back in 2013, we were at 50%. This year, it looks like we did go down a little bit. I think I can kind of understand a few things that possibly caused that, which I'll explain in a little bit. So as all of you are probably familiar with, working with the homeless population is quite difficult. There's no private facilities for clients to prepare for their colonoscopy procedure. A lot of them prefer to live outside. I've had several clients that don't like crowded places. They don't want to stay in a shelter. They prefer to stay in a tent or in an abandoned building. And then we do have a lot of clients that stay in kind of community areas with a shared bathroom, which poses a lot of difficulty for preparing for a colonoscopy for the next day. A lot of our clients also, they only come in on an emergency care basis. They come in when they need care for, either an infection or some kind of like sinus infection, lung infection is what we see a lot. And then they don't come back for follow-up. So that poses a lot of difficulty for us. Our clients, their priorities are very different than a client that isn't homeless. They're worried about their shelter, how they're going to eat their next meal. And if they have the opportunity to work, they take it. We've had clients that we've set appointments up for. They have a procedure date, and they get the opportunity to work that day, and they don't show up. So that, causes a lot of difficulties also. They don't have any reliable family or friends to accompany them to the procedure also. This has come up a lot with our clients. They have, because they're going to be sedated for the procedure, they need someone to bring them there, stay with them, and then bring them home. We have tried coordinating with one of our gastroenterology offices to see if they would be willing, if we set up a ride for them through a taxi company. We have an account with a taxi company nearby, and they're just not willing to do that. So that has posed a lot of difficulty also. A lot of our clients have a substance use disorder that, causes a lot of different difficulties with patient follow-up. The clients, their main concern is their substance of choice and whatever they need to do to get that, or if it's alcohol, which we have a lot of clients with an alcohol problem. They don't schedule anything, they don't plan anything, they plan their day around drinking. So that causes a lot of problems also. Also the address, they don't have an address to send anything to. So, if we mail them a Hemocult envelope with the cards in that, they have no way of receiving that, and they also, mailing it out is difficult too. We have been using the Cologuard, which is, the company Cologuard. They mail the kit to the client, and they do it in their own home, and then they send it in. But we have, nowhere to send that to. We have had some clients that prefer that for privacy-wise, and they don't like doing any kind of samples in the office. They don't feel comfortable with that, so the mailing is a good option for them. And I think the decrease in this year's rate is possibly a part of it related to that. We have had clients wanting to do the Cologuard instead of something else, which doesn't count on the HRSA UDS report. That's not included as a appropriate screening. So colorectal screening has been, as far as I can remember, at least for the past 4 years, it's been part of our quality improvement work. Our quality improvement group, we meet sometimes monthly, sometimes every other, and we discuss the challenges and the achievements that we've had with our quality of care measures, including colorectal cancer screening. We have a lot of quality of care measures that aren't anything that we need to report on, say for our UDS reporting or any of our other grants, but it's important to us to report on. So we have that as part of our work plan. So members of our committee, they bring a variety of experience and perspective from the medical. 3 of our members are nurses, 1 including myself. We have our medical director, who's a physician, Dr. Saranich-Kalkin, and we have another physician who is a retired cardiologist on our committee. We have a radiologist, and we also have a health insurance representative, which brings a kind of a good perspective, and I think she can bring good feedback to her company as well on the struggles that we have with our clients. This is the colorectal screening program grant that I was talking about in New Hampshire. They offered free screening colonoscopies through their grant. They couldn't be a diagnostic colonoscopy to patients who qualified clinically and financially. So it had to be a screening colonoscopy, and they had to meet the federal poverty guideline levels to be able to qualify, which most of our clients did. And they handled kind of from the beginning to the end, calling the patient to schedule, arranging the ride for them to get to and from the colonoscopy, handling getting the results to the client if they had abnormal results, referring them to the proper entity. It was a great program. They are still up and running, but the grant changed on how they work with facilities in New Hampshire. So currently they now provide support and resources to health centers in New Hampshire to help improve screening rates. So they come, they meet with us, they have a couple of representatives, and they come and see how our rates are doing, what they can do to help. They come and do staff learning sessions on how to talk to clients about colorectal screening. They also actually helped connect us with a representative to help get us the FIT testing for colorectal screening. We are still waiting on our supply of those. We haven't started that testing in this office yet. We're still using the HemoCult cards. So the medical director and I meet regularly with the program staff to discuss any challenges we may be having with screening rates, testing supply needs, and even insurance roadblocks. So if the insurance isn't covering something for some reason, a lot of the clients that we have now, if they don't qualify for the state Medicaid programs, they have to purchase an insurance. And a lot of them don't want to spend the money on insurance when they'd rather spend it on where they live, child care, things like that is what the feedback that we get from clients. So that poses a lot of difficulty also. So I wanted to mention our respite center. It's a medical respite center. It's the only one in the state of New Hampshire. It's an 11-bed facility within the same location as our outpatient medical office. So it's really convenient. It's right downstairs. So we're allowing patients who need to prepare for a colonoscopy to stay for one night in order to have a private space for preparation. We have a couple double rooms, but most of them are single rooms. And we haven't had anyone utilize that use for the respite center yet, but the option is there if a client wants to take us up on our offer. How we track abnormal results and how, if with an abnormal result, we follow up on that. So abnormal results are reviewed by the provider and routed to the nurse or MA that they work with a plan. They may need further diagnostic testing, referral, or future repeat testing. The nurse and MA then orders the testing indicated or the referral. and sends themselves a future flag, so they date the flag for a date in the future, and then they attach it to the patient's chart, so that way when that date comes, it pops up in their desktop, and it states that either they need to schedule another colonoscopy or they need to schedule a follow-up for gastroenterology or whatever the case may be. And then we also send out letters yearly and as needed to patients who are due for screening. That has helped out a lot when we send those out. We get a lot of calls from clients wanting to come in to discuss where they go from there.
Great. Thank you so much, Angela. We really appreciate your presentation. If the listeners have any questions, please enter them in the chat box now, and all questions will be answered and posted with the archived webinar on the Council's website at the end of the entire virtual training series. I want to also point your attention to our resource slide, and this gives you an idea of some of the different materials that are available. In particular, the first link is the article regarding colorectal cancer screenings for community health centers, and it does give a very good comparison between colonoscopies and the FIT test, and showing that there is no superior effect by using colonoscopies. And so if you're interested in finding out more about the efficacies of the FIT test, that article will give great guidance in that. Also, there's some more information regarding how to use community health workers or navigators to increase colorectal cancer screenings, and there's also materials available at the National Colorectal Cancer Roundtable website. So please take advantage of that information. We want to once again thank you for attending, and as a reminder, in order to claim CME credit, you must text in the provided code within 24 hours of this session ending. At the close of this webinar, an online survey will automatically open in your web browser. Please complete it for us because it helps us improve your webinar experience. And our meeting will now be closed. Thank you.